Actually, since we're a small group, if you all want to just raise your hand and interrupt me as I'm going through, I'm happy to take questions. We can have more of a conversation than just a monologue here. So we'll try to save some time at the end for questions as well, but if something comes up, I'm happy to take questions during it. I much prefer a dialogue. Okay, so why don't we get started? So as I was thinking about coming to speak today, one of the, here we go. Yes, yeah, lift off. Obviously many of you are very involved in the technology. How do we get all this data up? What platforms? How do we speed it up? How do we move it faster? And many of you are probably interested in also the techniques as data scientists. But I thought that what I could bring, what I could contribute really is a perspective from healthcare and what the challenges are. Because healthcare is not, I would say, taking full advantage of all the data and the big data that exists. And there are reasons for that. And so maybe I can give you a glimpse to those, as well as what some potential is, what some of the use cases and potential opportunities there may be going forward for the use of data. It's a little ironic. Healthcare has always really been very science-oriented. Obviously, it's medicine. And they rely heavily on data, but it's really data at an individual level as opposed to data in an aggregate level. So there's quite a bit of irony in the industry as we look at it. So what I thought I'd do is start at least talking a little bit about Kaiser, kind of get us to a baseline, talk about our health information technology investment, and then talk about how we're using data at Kaiser. Okay. How many of you are Kaiser members? Okay. And how many of you are, I'm from out of town, I'm from Vermont, Kaiser what? Have never heard of it, don't have an opinion? Okay, so most people have some familiarity with it, and a few of you are members. We're the nation's largest nonprofit health plan. We actually are an integrated healthcare delivery system, which is unusual, right? So we're like Blue Cross and Aetna in that we insure lives. We have 10 million people currently in the Kaiser, actually more than 10 million people, members that we insure. And we are a chain of 38 hospitals. That's quite a few. And then we have 5 physician partnerships. So Kaiser Permanente, the physicians are not employees of the corporation. They are part of an independent partnership. So they come together and they have partnerships amongst themselves. And then they have a mutually exclusive relationship with Kaiser. So Kaiser Foundation Health Plan and Kaiser Hospitals are nonprofit organizations, and then we have a mutually exclusive contract with the physician groups, right? So they only take care of Kaiser members, and Kaiser members only go to them, or at least initially. Sometimes they'll get referrals for something like that. So that's how that works. This year we'll be over $60 billion in revenues, and I just looked it up recently for this meeting, and if we were in the Fortune 500, which we won't because we're nonprofit, but if we were, we'd be number 47. So we are a significantly sized organization, almost 200,000 employees. Okay, our performance. We have patient and member service are ranked highest according to J.D. Powers for the regions that we serve. We have quality of care above the 95th percentile according to Medicare. They give out these star ratings and look at 55 measures of quality and service. This is quality of care. And then in terms of cost, our plans are 7% more effective than competing plans in their service area. This was an external study that was done in 2014. And obviously there are a lot of factors that go into that. So our performance is pretty good. We're in healthcare, this is what you strive for, right? Good quality of care, low cost, high patient and member satisfaction. This is really hitting it out of the ballpark. But I'm going to tell you a little secret. We weren't always that way. I would say 10 to 15 years ago, we were fair to good. There were pockets of excellence, and then there were pockets where we clearly needed to work some more. And I will put to you that it is our use of health information technology, the electronic health record, and big data that has allowed us to get to the next stage in terms of our organizational performance. And we have yet to really fully tap those mechanisms and endeavors. Obviously, there's a lot of other things that go into it, leadership and culture, and lots of other hard work, but really in terms of a leveraging tool, the electronic health information technology, the electronic health record, and our data. Okay, this is more of the same. So let's talk about the electronic health record. We made a $4 billion investment in our electronic health record, which we bought from a vendor called Epic. In fact, I was just there yesterday. I was in Madison, Wisconsin at their conference. And it essentially represents one single medical record for a patient across their lifetime, both in the hospital and in the clinic, every phone call, every contact, every secure email, every piece of information. So having that coordinated and sitting on top of our data, and we derive our data repository from that. That looks very simple, but we have 16,000 Clarity tables underneath there that get informed by all of that transactional flow that goes on in the electronic health record, right? And it includes everything, all the appointments you made and missed. It includes every phone call. It includes every comment that the physician made, what the patient reasons for visit, et cetera, et cetera. This is different. This is different than a lot of our healthcare represents. A lot of our healthcare is very fragmented, has bits and pieces of a patient's experience, and we really try to consolidate it and use it at the center of all the other information we hope to build on it. We were just talking before the break, before we started, about all the different kinds of data that are coming in at us. But we use this data, the electronic health record, the clinical experience as the organizing schema for the rest of the data. So other kinds of data, patient-reported outcomes, data that comes in from the patient that says how they're feeling, that's collected in an organized way. Data from remote devices. Sometimes it's Fitbits for instance, for orthopedic knee surgery patients that you want to monitor their activity rates. We will monitor hemoglobin A1C. We will monitor all kinds of other signals from the patients in order and associate it with the electronic health record, because this becomes the organizing schema, right? Let's see. The other exploding element that we are just beginning to understand and to associate with the medical record is genomics. And pretty soon down the road, probably microbiomics and the proteomics. And the numbers start to get exponential. That is a lot of data. And we are still grappling with how to move that amount of data into our systems. We currently have a genetics lab. Well, we have many genetics labs, but we have a genetics research organization that is beginning to grapple with how the collection of that information and the association with the clinical data is really very, very fruitful for research down the road. So you can see it's at the core, and again, one medical record for the patient across the entire continuum of care, which can be very complicated. We also include all of the outpatient pharmacy information, because we have our own outpatient pharmacy. Most of our members get their drugs from Kaiser, and so we understand not only what was ordered by the physician, but also what you ended up showing and getting, and how often you're getting them, and what your dispense rate is. We have all your lab results. We have the imaging and the radiology results, not only the interpretation, but the images themselves. We have that electronically. When patients email us their conditions, sometimes they'll attach an image. hey, doc, I have a rash. Is this something I should worry about, right? And so those scans are also included in the medical record. Everything you can imagine. And then sitting on top is we have kp.org, which is a patient portal that gives patients access to their own information. It's not everything, but it is a view to their own diagnoses, their problem list, their medication list, their allergies. They can look at information from their past visits, and they can securely email and their physicians as well as get refills for their medications.
Is this PHR or be a part of PHR?
This is the PHR, right. So it is our personal health record isn't just kind of a standalone. It sits on top of the electronic health record so that the same data the patient sees is what the physician sees. So they are one and the same, right? It's like getting your own banking account access to your information. It is your information and it's real time. It's real. It's not a derivative. It's not information that you have to input yourself. It's a derivative, and oftentimes, and for lab results, the patient will get them at the same time that the physician gets them, right?
For the scheduling and registration, the practice management part, do you have a specialized thing for Kaiser, or do you use the existing?
Most of our regions use what is part of the vendor package, but actually Northern California, which we're sitting in, has its own scheduling mechanism that interfaces with that. So again, we had a bunch of legacy systems that we're still interfacing to. Question?
Two-part question. Finance, health plan, ancillaries, do those all feed into the data repository? Is that what those arrows are?
We have real-time interfaces with the electronic health record. We hope to be able to make the association with finance so that we can cost out the clinical care in a more direct, granular way down the road. But that's down the road. But we have real-time interfaces to those systems.
And then what percent of this data overall, maybe by category, is unstructured?
Ooh, good question.
80% rule?
You know,
I
God,
think the record is partly unstructured.
Yeah, oh yeah, no. Lots of progress notes, lots of social history where there's a lot of typing of information. Plus, there's all the images. I don't know what you want to,
Right.
There's all the images. So I don't know how you classify those. But there's a significant portion, but again, we try to get to discrete elements for obvious reasons, as quickly and as often as we can. And we'll make choices for physicians. So there are drop-down menus to pick from things so that they don't have to type in. That saves them efforts, but it also allows us to get to common terms that they can pick from, right? Gosh, I'm afraid to guess. Yeah. Okay, I think there was a couple more, and then I'll go through some more slides.
I think I'm sort of curious. If I look at your inpatient part, right?
Uh-huh.
And I see ER. Are you looking much at ICUs and instrumenting it? Because ICU is supposed to be about 40 to 50% of the cost of healthcare, right? If you look at the Garrido.
ICUs are very expensive, and there's a lot of data in an ICU, and a lot of, you're right, devices monitoring the patient in almost every imaginable way, right? So we probably keep a subset of that data as it passes into the electronic health record. Some of that data is more for the care or for nurses to manage and monitor, and they'll make notations about key elements. So we're still sorting through actually that integration between all those devices in the ICU and the electronic health record, and what is the appropriate level of information, because that is streaming data. And it can get overwhelming. So how do we manage that information? And you're right, it's very expensive, although I'd say that there are many expensive items on that list.
So my point is, if you think of it, because the reason it also refers to my talk that's going to come up, I'm sort of very intrigued. The point seems to me you've got inpatient, outpatient, right?
Yes.
And I think the progression today is from inpatient towards outpatient. In other words, can
Right.
we be monitoring
You
people all
try
the
to,
time?
oops, go, keep talking.
Can we be monitoring people?
Great.
Can we be people monitoring all the time, right?
Yeah.
Continually.
Yeah.
So the fundamental thing is, I'm sort of curious because what is your approximation to what I term the patient health state? What we have are a bunch of records.
Yes.
What we lack today is a notion of where is the patient in the health state sense
Yes.
so that you can plan on the intervention as necessary.
Yes.
And what is the crude approximation? Because I've got more analytic models. I'm curious, what is the crude approximation you're using right now?
Right, right. So excellent question, and it's a direction that we're moving in, both from an inpatient state as well as an outpatient state, because there's ways of managing and monitoring patients on an outpatient basis as well that are equally important. You talk about a patient with depression, right? A patient who you want to stay close to, diabetes, children. I was just looking at a model for pediatric diabetes where you not only does the healthcare organization want to know, but the parents want to know what's the blood sugars for the child and are they keeping up with that, right? And so what are the different models and the ability to keep up with all that data on an ongoing basis? And streaming is relative, right? Whether it's within a second or kind of every couple hours, right? Yes. Dynamic, thank you.
I
Yeah.
have only a question, you don't have to answer, just to see if you could cover. The different data, which is healthcare, non-healthcare, billing, etc., relationships and relevances, is there a graph that you have?
Graph. I would love to have that graph.
Oh.
That is, because in some ways, healthcare is the healthcare of those patients that you're trying to manage and monitor over time.
Yeah.
It is almost everything you can imagine. The weather, pollen counts,
Okay, got it.
right? I mean, socioeconomic levels. It's well known, and I have a graph later on about that socioeconomic, probably your status. Do you live next to a power plant, right? What kind of water do you drink? So the amount of data that we are able to at least posit has a relationship with healthcare status is almost infinite, right? And so the challenge becomes, how do you pick? What do you stream into the electronic? We're at that crux right now. What do we bring in? What do we bombard our already very busy clinicians with? And how do we manage these new sources of data? But the electronic health record, and back to the theme, is pretty much where we want to go. Last question, and then I'm going to move on.
Much more than structured and unstructured, healthcare technology is an unsolved problem.
Yeah.
So how do you deal with that? I mean, do you come across healthcare technology?
Yes. So yes, medical terminology is a big challenge. We subscribe to a classification system called CMT, Convergent Medical Terminology, which includes things like ICD-9, CPT-4s, SNOMED, and tries to knit those different classification systems into kind of an overarching medical terminology. That said, and we have some expertise in that area, it still can be challenging, right? Because there's what you see in the progress notes to the physicians, and they'll use shortcut names, right? I was just talking about this. CHF, is it heart failure? Do you just call it congestive heart issues? There are many names for the same thing. Doctors know what they're talking about, but when you're trying to do searches, when you're trying to understand what these things are, it can be a challenge. And obviously, so use of NLP and contextual is something that we're beginning to really understand and work through right now. Okay, I'm going to keep us moving. Lots of interesting themes, and we can keep talking about this, but I do want to get to some more content. So this was back in 2012. I'm going to guess that we have probably more like 12 to 15 petabytes of data in storage. That's the other thing. We throw no data away. Since we probably have paper records from the 1940s when Kaiser first started up, and we've kept them. The idea is that they may be useful for research. And obviously not for those patients today, but their grandchildren. We have entire families, histories of families, right? That can be really valuable research-wise. And so we have paper records and microfiche stored in some mountain somewhere, but obviously we have a lot electronically, and that's, again, growing exponentially in terms of the data we have. Now, I was asked previously to talk a little bit about how we do analysis and do the data, do analytics on the data. We currently, one of our workhorse engines is SAS. We have about 5,000 users of SAS in our organization, 1,500 of which we call power users. They do go in, extract the data, and do manipulations as well as put out reports, et cetera. Many of these people are data scientists. I have a group of PhD folks that have PhDs in statistics on my staff who do modeling, relatively sophisticated modeling, and predictive modeling as well, in order to be able to come up with new ways of getting insights into our healthcare. For instance, we just did a study on thyroidectomies. Are they safe to be doing these kinds of surgeries in an outpatient or inpatient basis? Well, there are a lot of questions that go into that because you have to acuity adjust for all those things. You have to adjust for and it turns out that the big factor is less about inpatient, outpatient, and does your surgeon do enough of a volume in order to be able to assure the skill sets that they're needed. So again, many factors go into making decisions even about site of surgery as we look at results, as we try to understand what's best for the patient. Okay? Yes, question?
Is that with the existing data you have, or you?
That's with existing data. Sometimes we will do things, for instance, the urologists were looking at microhematuria, so blood in the urine, and they created their own smart forms within the electronic health record to collect that on a systematic basis for those patients so that they could then have the data to be able to do the analysis. But for the most part, we're sitting on a very rich gold mine of data, and many of us feel like we have not even really tapped what the potential is there. So let's keep going. So I was going to talk about, and I want to be mindful of the time. When am I ending? Okay, so we have 15 more minutes. So let me talk to you at least about 2 use cases that'll just give you a glimpse. We've talked about a few things here already, and I was going to go through kind of, there are things at a macro level, so healthcare knowledge, how do we contribute to that? All the way down to the micro level, how do we give patients access to their own information so that they can self-manage and understand create their own feedback loops on how they're doing and help to manage their own care, and everything in between, right? Organizational level, how do we make decisions about where to invest and what quality of care indicators, because unlike the banking industry where you can boil everything down to a net profit, we can't just look at that. We're nonprofit. So certainly we care about our financial health, absolutely, but we also care how are we improving the care of our members. And so we look at many quality of care indicators, and there's no one thing, right? Quality adjusted life years, well, what about the OB patient? What about the Parkinson's patient who, there are many different kinds of outcomes that don't collapse very nicely. So we end up in healthcare looking at many measures. There are many metrics. And so for that, we use a balanced scorecard approach at an organizational level. We also look at patient populations, and I'll talk a little bit about an example of that, to understand not just the patient that's in front of you, in front of the doctor asking for services, oh, I came in and sprained up my ankle, but really the patient that didn't show up sometimes is really the patient that you want to be paying attention to. Mrs. Jones, who has diabetes, who is unmanaged and hasn't come in for 2 or 3 years. How do we avoid her getting some of the complications and ending up going blind or losing a foot because she's not managing her diabetes? So it's the patient population and the ability to use data to understand how the care gaps and the issues for our patients at large is very important to an organization like Kaiser, who worries about health and not just the medical care that's given to the patient in front of you, right? And then there's physician level information. There's physicians that historically, physicians have been kind of entrepreneurs. They're independent. They I'm not quite sure how they judge their kind of performance once they leave medical school. Maybe it's their bank accounts. Maybe it's the number of research articles they have. I'm not sure exactly how that works. But at Kaiser, what our medical groups do is they think about how do we hold ourselves accountable for good quality of care? What are the metrics? And how do we give each other feedback on and look at our performance as peers? And how do we keep improving that? So that is actually a really important place where data is coming into play to really help inform and change our performance for these physicians and clinicians and other clinicians, nurses, physical therapists, fill in the blank. Folks are looking at metrics to help them understand their performance and improve. And then I have already talked about the patient level, giving them access to their own data. Okay, so I'm going to talk a little bit about this, which I call the tale of two studies. So I'm going to start out on the left-hand side here, and I'm going to talk about ALHAT. This is the anti-hypertensive lipid-lowering heart attack trial that was funded by the National Heart Institute for $120 million. Big money. To really answer some fundamental questions about how do you avoid heart attacks for the American public, right? Big, juicy question. And after 8 years of work, looking at 42,000 patients in a randomized clinical trial, they found that thiazide-type diuretics were most effective at controlling hypertension. If there was one thing you were going to do, that was what you were going to do. Well, thank you very much, people of ALHAT. That is a contribution to knowledge, right? If there's one thing you're going to do, you can use these diuretics. And by the way, these diuretics are pretty cheap. There are lots of choices, and this is pretty cheap, so that's good. It's good to know that I can use this as a first kind of line of defense and understand what I need to do for my patients, again, to avoid heart attacks. But we had a physician researcher at Kaiser in Denver who said, well, that's good, but what do I do next? What if that doesn't work for my patients? What if that's not enough? What's my second line treatment, okay? So he instead, at a cost of $200,000, using 4 million patients, looked into the question and found out that for 60% of patients that couldn't get under hypertension control using diuretics, ACE inhibitors and beta blockers were effective as second-line medications. Well, thank you, Dr. McGitt. That's a contribution to knowledge. So if the diuretics don't work, go to beta blockers and ACE inhibitors. Great, great. Now, very different studies. Again, I have a background in operations research and statistics. Very different study, right? You have a randomized control trial with ALHAT, okay? As a statistician, that's the gold standard. I can't tell you anything else, right? It eliminates patient bias. However, there are statistical techniques, propensity score rankings, that allow and help you match control cohorts that help you adjust for patient bias. So you can't get rid of it, but you can adjust for it. Okay. The ALHAT style trial was a limited target group. All right, this was predominantly middle-aged white men. I think they threw in a few African-American men at the end. So it's a limited target group. I have to tell you, as a Mexican-American woman, I felt a little left out. What about me? Dr. McGitt used our patient population, which has everyone, right? It has the huge diversity that is California. The ALHAT trial were controlled situations. Every patient and every doctor knew they were in this trial, right? Whether that changes their behavior or not, I won't posit it, but I can assure you that Dr. McGitt's study, there was no change. It was real-world condition, right? Hey, doc, I just lost my job. I've cut my medications in half, or I haven't taken them for the last couple of months. These were real-world conditions. So I'm not gonna. I'm not here to debate the pros and cons, like which one's better. They're different, and they have their strengths. They both have their strengths. But it does give us this access to these clinical records, right, and allows us to think about how we contribute to healthcare knowledge in a very different way than we have historically, right? It allows us to make assertions differently. Okay, the next is the patient population level, which I really like. So I think many of you, I'm going to guess, may have heard there are new organizations. People are now thinking about how do we manage patients with diabetes and kind of get them in for screening on a regular basis. Well, we've done that. We've been doing that for a few years now. And so we're taking it to the next level. We're looking for not just the diabetes and the heart conditions, which are kind of the big hitters, but we're taking that concept and we're now going for many different kinds of care gaps that exist by putting in a monitoring, auditing function that kind of really surveils the population to look for care gaps, right? And that's probably enough said about that. What we do is we sort through kind of what are some of the care gaps that clinicians have seen in the past. In this case, it was a AAA, which is an aortic abdominal aneurysm. And what you're supposed to do when you have a patient that has one of those is not necessarily do surgery all the time, because surgery can be dangerous as well as expensive, but monitor that aneurysm to see if it grows. And if it grows, then you do surgery. Otherwise, if it doesn't grow, you know, it's okay, right? But you want to catch that aneurysm early on, because if you don't, if it ruptures, that's very messy. Patients show up at the ED. It's very messy, difficult surgery, and the mortality rates are not great, right? A lot of people die on the operating table when that isn't managed. So what we did is we have done a process whereby we identify those patients, and back to the earlier questions about unstructured data, a lot of times these patients this was not coded for an aneurysm. It was in the progress notes. It was in the history that the patient gave. So being able to search through those medical records for those mentions to identify who's the right patient. And then algorithms to determine, well, did we fast forward and within 2 years, did this patient have something that looked like it was a way to monitor the patient? Was it an ultrasound? Did they go to interventional radiology or get some kind of imaging taken to monitor that? So the algorithms to identify were the right steps put into place. And then a reduced list of those patients that we had questions and identified had potential care gaps to be worked through. So this is what it's allowing us to do, is to create a backstop. We're actually branding this as a sure net. Okay, these are outpatient safety nets to help support physicians as they give care. Sometimes patients switch doctors, or they forget to mention they have this. Sometimes they move. Sometimes doctors retire. Sometimes you've got very long list of different conditions, and so the aneurysm's at the bottom. So how can we help support the healthcare system to identify all of these care gaps and potential places to fall down? And that's how we're using some of our data. So I'm going to stop there. Those were just a couple of use cases, and I've kind of just mentioned a few others about, and you could just see this explaining. You could think about this idea in terms of care gaps, not just looking for them a few times a year, but rather on a regular basis, right? Or in an ICU. So there are many applications right now, and we're really pushing on all of these, both conditions and possibilities, opportunities to really enhance care for our patients, as well as reduce costs.